All right, well, let's go ahead and get started. My name is Cinnamon McLaughlin. On behalf of the Employer Advantage team, I would like to thank you all for joining us for the second installment of our DPC webinar series. Today's topic is, should your DPC practice engage self-funded or fully insured employers? I'd just like to briefly outline our plan for this webinar. All attendees are going to be muted for the program, but there will be a 5 to 10 minute Q&A session at the end, so you will have an opportunity to ask questions. Our speaker today is Jed Constantz, Chief Strategy Officer and Senior VP of Client Relations for Employer Advantage. Welcome, Jed. You have our attention.
Thank you, Cinnamon. And before I start, I'd like to introduce Mike Tuggy. Mike represents Family Medicine for America's Health. We are in a collaborative arrangement with both Family Medicine for America's Health and the Family Medicine Education Consortium through what we call the Primary Care Innovators Network. And this webinar, the whole series of webinars, are actually a continuation of a discussion that happened in Arlington, Virginia a few weeks back at the DPC Summit. And I want to thank Mike and his organization, obviously the FMEC as well, in helping us put together that program a few weeks back, which was frankly quite successful. And the plans are to move it from a single session to a half-day session next year at the DPC Summit. So stay tuned for that. But Mike, if you would say a few words and kind of welcome us to this conversation today.
Yeah, thanks for having me on today too. And I just wanted to just give a brief background as to how Family Medicine for America's Health has been engaged in this type of work now for the last almost 4 or 5 years. The Family Medicine organizations about 5 years ago was looking at the state of healthcare in this country and the state of family medicine in particular, and we recognized that there were some key things that needed to happen in order to improve our health system and also make primary care more effective. And we developed a strategic plan around communications, which is the Health is Primary campaign. And then also it's the strategic work around how do we change healthcare delivery and payment, because both of those things are so intricately tied together. And one of the key learnings that we uncovered in the work that we did looking at different practice models was that a comprehensive primary care payment model suits the incentives of primary care much better than fee-for-service. And so one of our main strategic objectives is to work on transforming our system into payment models where family physicians are paid to manage populations of patients, risk-based, but at least having a fixed payment structure that doesn't involve billing and coding in the sense of using that to determine your payment. And so this really stimulates much more population health incentives in the work that we do, but also makes costs of practice much less as well. So, our engagement with Jed and FMEC and the DPC network is, closely tied to basically the alignment of the work that the DPC practices are doing, which is a form of comprehensive primary care payment. So we are fully engaged with this team that we have with the PCIN, and we look forward to continue to work with you guys in the years to come as we develop more sites that are using this payment model.
Excellent. Thank you, Mike. And again, I'm sorry, did I cut you off?
Nope.
Oh, okay, cool. And actually, that's the most important piece of this whole conversation is to really look for opportunities for primary care, payment to primary care, to be viewed more as an investment in primary care, and thereby allow those who finance care to really begin to understand the value of doing that, and to try to keep the conversation focused on that, and to distinguish between, appropriately so, distinguish between services that are provided in the primary care realm versus those services that are provided for some other purpose in order to provide care and treatment to the patient. And so part of the discussion here is it will apply to many direct primary care model practices, but frankly, it won't apply to those who really are not interested in doing anything beyond just reestablishing a value-based relationship with an individual patient. And so I like to say that at the outset, because what we don't want to do is cause folks to believe that this is a necessary component of a DPC model practice, but it can be an important component of a DPC model practice, depending upon where your practice is and what your objectives are. We talked about it at the previous session, the fact that working with employers gives you greater opportunity to enroll populations of patients into your DPC model practice. And in this particular session, we wanted to spend some time really talking about the difference between the self-insured or self-funded. Both terms mean exactly the same thing. Whether an employer is self-insured or self-funded, we mean the same thing, or a fully insured employer, and what those differences look like. And so we have some illustrations that we're going to look at today that help folks quickly distinguish the difference between self-funded, self-insured versus a fully insured. So as you look at developing an employer strategy for your direct primary care model practice, and again, to the extent that that's something that you genuinely want to do, it's important to understand that self-insured employers, as we talked last week, have different needs and as a result are looking for different services than fully insured employers. And when you begin to understand the underlying economics, you can immediately begin to recognize why and why these differences. And then this conversation today and the questions that will follow later hopefully will give you the opportunity to think a little bit more clearly in terms of what type of employer should your DPC practice focus on if you want to have an employer engagement strategy as part of your overall effort. Now, we certainly support the idea of working with employers because we believe it helps communities really begin to adopt a true value-based, primary care-driven model that ultimately holds the promise of making healthcare more affordable in the community as a whole. And this type of primary care to business partnership, we think, really helps to strengthen that conversation and will set aside a lot of the myths and misconceptions that exist in terms of those who pay for care versus those who actually provide the care. So, again, as I've said earlier, it's important to understand the difference between a self-insured or self-funded employer versus a fully insured. And then what sort of characteristics do we often find in those two types of employers? So to look at this from the standpoint of an overview of the financing models, the fully insured, they tend to come in two flavors, if you will, and it depends upon how each state's Department of Insurance might regulate the way health plans are offered. And I know there's a lot of disruption right now or confusion right now with respect to what's going on in the so-called exchanges. But at the end of the day, what remains a constant is that in many states, fully insured products, if you will, are either offered on a community rated basis, in which case what the employer pays as a premium on behalf of the employee and their covered dependents has absolutely nothing to do with what the claims experience is for that particular employer. And community rate employers are typically less than 50 employees. In some states it's a different number, but typically less than 50. And what the insurance company will do is they will come up with a variety of products, if you will, that are intended to be sold in the so-called community rated market that are pretty limited in terms of flexibility and choice. More and more often, in order to make them affordable under the current circumstances, they are high deductible plans where a lot of the front end expense is borne by the covered individual. And in those instances, the interest in the direct primary care model would fall in in those circumstances where folks really wanted their basic healthcare needs addressed, and they pretty much recognized that unless they had a catastrophic event, they were probably not going to tap into the benefits that might be available under a fully insured, community rated product. For another form of fully insured, and we're getting a little closer to self-funded or self-insured, if you will, but a little closer is something that's experience rated. And these are typically employers that are over 50. And in many states, when you're over 50, you have to buy a product that is actually experience rated, in which case what you pay this year in premium is based upon what you did last year in terms of claims expense, or possibly 18 months ago, as opposed to a pure 12-month period of time, based upon how much time it takes in order to calculate a new rate. So in some cases, it's 12 months, and other cases, it's 18 months. But regardless, in this instance, a fully insured employer who is experience rated is actually paying a premium rate that is calculated based upon the actual utilization of services by their population of covered individuals, again, 50 or more employees covered under the benefit plan, and their eligible dependents. Plus, there tends to be anywhere from a 20 to 30%, what I lovingly refer to as fudge factor, which is designed to truly protect the interests of the insurance company in case there is a truly catastrophic experience that occurs with that particular employer, and the insurance company wants to make that they have collected sufficient premium dollars in order to offset that and allow the employer to weather that incredibly bad experience until the renewal can occur, and a new premium rate that then factors in whatever that catastrophic event might have been on a go-forward basis. So, but in both instances, it's not the employer's money directly. Certainly for the community rated, it's never the employer's money directly because they're in this community pool, often driven by the level of utilization that exists in that underwriting area, which could be a pretty broad geography depending upon the population that exists. It's not always a county, it's not always a region of a state. In fact, in some cases, it could be the entire state, which is the community rated region based upon the population. You won't see a community rate that extends beyond state borders because, again, fully insured products are regulated by the various states' departments of insurance. And so, you know, there's talk about being able to sell products across state lines, but that we're far from that yet, frankly, because of the very protective nature that states' departments of insurance have over what products they allow and what rates they try to allow as well. So, but that's what fully insured is. It's somebody else's money, meaning the insurance company, and the mechanisms that are in play are intended for the insurance company to bear the risk essentially at the very outset. But in the case of an experience rated employer, they ultimately have to step forward and pay for what utilization actually occurs. In that scenario, the value of a direct primary care model will vary depending upon whether it's community rated or experience rated. And we'll sort of talk about what those values might be. But you can begin to see that the real dollar impact of direct primary care for a fully insured employer is pretty much limited in this instance. For self-funded or self-insured, again, same term or same meaning, two different terms, it is the employer's money. It's what we often refer to as the employer's money to begin with and the employer's money to end with. This is genuinely the opportunity to talk to an employer and truly promote the value of well-organized, well-orchestrated delivery of primary care, in the sense that primary care can deliver a pretty broad range of services to patients and in many instances prevent, frankly, the patient from needing so-called downstream care or specialty services. Not always, but often. And so it's a different conversation with a self-funded or self-insured employer, because they would see the impact of your efforts as a direct primary care model practice almost immediately in the claim that's never filed. Because in both instances, what they have essentially done is they have executed what's known as an administrative services only agreement with the claims administrator, who could also be an insurance company. But they've executed this administrative agreement that allows the insurance company, if you will, or claims administrator, to pay claims by tapping into a corporate bank account that belongs to the employer, but becomes the source of funds for claims that are actually paid. So in that instance, unlike the fully insured environment, it's real-time money to this employer. Now, they may have calculated, with the assistance of the insurance company, a so-called premium rate equivalent number in order to budget for claims for their self-funded population. But like I said, at the end of the day, it is the employer's money. So in that instance, what you're proposing to a self-funded employer is genuinely a pay me now versus pay me later concept, because again, it is their money, and they have all kinds of flexibility that many of them really don't realize they have, and that often you then become the messenger for how flexible things can be in order to produce or provide them with a much better benefit plan strategy for themselves. Partially self-funded versus fully self-funded has to do with what sort of reinsurance the employer might buy separately in order to protect against a catastrophic situation. So that even though the claims administrator has access to the bank account, the employer has purchased separately stop loss or reinsurance that is designed to protect the employer from a catastrophic event that would otherwise drain the bank account. So, and those are referred to as recoveries against a catastrophic claim. And there are different levels of attachment point, as it's referred to, in terms of how big a dollar number are we talking about before the employer can recover monies from their reinsurance carrier in order to protect the financial integrity of their benefit plan. And fully self-funded are those who don't buy reinsurance. They are large enough corporations and entities so that their own corporate proceeds themselves provide the financial protection that they need. Smaller employers are partially self-funded and have, again, various levels of reinsurance in place in order to provide for that. But again, that's the important distinction. So the fully insured employer and the self-funded employer may be using the same claims administrator, but the difference has to do with, as I said earlier, whose money is it at the time the service is provided. And in the case of fully insured, it's the insurance company's money. In the case of self-funded, it's the employer's money. Now, how big do you have to be self-funded? It depends. It depends upon the population. Certain populations, you got to be pretty big based upon the risk factors associated with that population. Other populations, you can be pretty small and still self-fund because the risk factors inherent with your particular population are less. And so there's really no magic number. We like to point to 500 and up employees in a given geography as a meaningful starting point in terms of a nice, stable, self-funded group. But frankly, we've seen self-funded groups as low as 50. It just depends upon who the group is and what their circumstances are all about. So when we start to really look at the fully insured employer's needs, they have certain characteristics and as such, certain needs. Now, what they would all like to have and are pursuing as much as they can are these higher quality benefit plan strategies. Because as we mentioned in the previous session, benefit plans are viewed as an extension of the compensation plan. And even small employers who are fully insured are trying to do what they can to recruit and retain high quality employees. And so they realize that they want a higher quality benefit plan so that folks will not necessarily gravitate to the large employer, but will seriously consider working for a smaller employer who is fully insured. Often, again, because of the trends, I mean, we're 12 years out from the introduction of the so-called high deductible consumer-directed health plan strategy and concept. And what we've seen is that it's been very successful at causing folks to deny themselves access to needed care. And it's been very successful at creating a patient population with more chronic condition types as a result of those financial limitations. So the fully insured employer who is offering a high deductible health plan, even one who has introduced an HSA element to it, they really want an opportunity to offset the impact of the high deductible plan design on the perceived value of the benefit plan, and frankly, the unmet needs of their covered individuals based upon the fact that folks are self-denying themselves care. The fully insured employer, for all the right reasons, would genuinely like to improve the health status of their population, if indeed that is an issue with their population, and recognize the need to improve the health literacy of their population, because that's a critical component, particularly for those of us that believe that a highly activated patient, as defined by the University of Oregon, is a good thing. One who is literate regarding their own circumstance and condition, and as such is able to work more collaboratively and cooperatively with their physician. And so the fully insured employer would like to do this. It doesn't mean they're not doing it now. What it means, though, is that they often buy these kinds of services in order to effectuate this strategy from a variety of vendors that are in the community. And this improved health status, and frankly, this improved health literacy, helps to improve healthcare consumer behavior. The feeling was, if we make it hurt financially, folks will figure it out. The reality is, all you did was make it hurt financially, and folks didn't figure it out. They didn't have the resources they need. They didn't have the support they needed to be able to figure it out. And so our message to the employer, whether it is fully insured or self-funded, is that your primary care community really should be your best source of information on a patient-by-patient basis regarding not just health status issues, health literacy issues, but how best to consume healthcare services in a given community. For self-funded employers, similar but genuinely a different set of needs. The first thing that self-funded employers that we talk to, once they realize what's going on within their own claims history, when they begin to realize how much of what is spent on healthcare is just pure waste. The Institute of Medicine was correct, 20 to 30% waste. The recent JAMA article about low-value care is correct in terms of how much healthcare waste we have because folks are pursuing what's paid or what's covered. Clinicians are providing services pretty much limited to what gets paid for. Patients are gravitating to services that they perceive are covered, regardless of whether the two of those align with the actual needs of the patient. And in order to do an effective job of eliminating healthcare waste, they need greater mechanisms to control downstream spending. This is not new. They have been trying this for years using various pre-certification programs, prior authorization programs, or what I affectionately refer to as 1-800-JUST-SAY-NO programs. Often at the expense, frankly, of other types of services that the patient might genuinely benefit from. The classic example in this scenario is behavioral health. The way behavioral health in this country has been financed and delivered has really created a gap in quality behavioral health service. They also want to improve health status and health literacy. In this scenario, and as the same with fully insured, is they recognize that a healthier workforce is tends to be way more productive in terms of what they do. But in this scenario, self-funded employers would also like to see health status improve. They would also like to see the highest level of health literacy because they too want to improve consumer behavior. Unlike the fully insured, where they're spending the insurance company's money, in the self-funded world, it's like giving every covered individual this credit card with no spending limit and suggesting that they go knock themselves out in terms of what they spend. And there is this weird perspective on the part of employees and covered dependents that I have this benefit plan, and so I better darn well use it. And because I want to get my money's worth, even though it's not theirs, it's the employer's money. But since it's always been presented as a form of compensation, you often get this demeanor of individuals who believe that they need to use it or lest they lose it. So they also, self-funded employers that we talk to, frankly, and this came up in the previous session as well, not all employers are going to be well suited for this. And this also is your opportunity to vet whether or not you have any employers in your market who are properly positioned to really, first of all, understand the value of primary care, and then secondly, work collaboratively with you to leverage the value of primary care. Not all employers are there. I mean, the previous session, we talked about an employer with high turnover rates. That's not someone you want to work with. They don't view their population of employees in the same manner as an employer with low turnover rates who genuinely is interested in offering the highest quality benefit plan. And so the self-funded employer, once they begin to understand the role and responsibilities of all of the component parts in offering a high-quality benefit plan, recognize that they need to reduce the role of the carrier or claims administrator. And we point to this because often they will buy things from the carrier or claims administrator, frankly, that are better purchased from high-performing primary care. And for us, it falls into three key areas. Obviously, wellness should be delivered by primary care and not by the carrier or claims administrator. Disease management should be delivered by primary care and not by the carrier or claims administrator. And then finally, care management, care coordination, making sure that the patient works their way through the healthcare system effectively and efficiently, we believe is a primary care deliverable and not something that should be offered by a carrier or claims administrator. So with that as a bit of a backdrop to the difference between a fully insured and a self-funded employer, let's start to talk about what you might want to create in terms of a product line strategy inside your direct primary care practice. In fact, many of the primary care practices that we work with all across the country recognize that flipping to 100% direct primary care works for some primary care clinicians, but may not necessarily work for them. And so the kind of guidance and support that we offer primary care practices that are part of a business arrangement with us and an employer, part of the support is to teach them the meaning of developing a product line strategy in order to make this migration either in total or in part to the direct primary care model, where for a portion of their patient population, they are getting paid in advance of care, and for a remaining portion, they are continuing to provide some semblance of fee for service. So the same sort of logic applies as you take stock of which employers are in your community and which ones you think you're well suited to work with, or frankly, you'd like to develop the ability to work with. And so, again, part of what we do is once we are introduced to a community, and often we're introduced by pockets of primary care clinicians that are interested in making this happen, we then work alongside the primary care practice, ultimately for purposes of becoming a vendor to the employer. But nevertheless, we sort of see it as a process of conditioning the market in order for this particular strategy to take hold. And we are, based upon the feedback we got from the DPC Summit and the feedback we've gotten over the past, actually year and a half now, we ourselves are thinking along the lines of a product line strategy for the so-called employer advantage model that would benefit the fully insured employer as well. So so again, going back to the way care is underwritten, frankly, you want to have a community rated model that is for those employers that are less than 50, whose premium rate has very little to do with the experience actually of their own population of individuals. You then also want to look at creating an experience rated model where you recognize that today's payment is not necessarily connected to today's claim, but will, however, show up next year in the renewal process. And so in that, so getting back to the community rated model for a minute before we leave that, that means enabling that employer to enhance the benefit in a controlled primary care model arrangement so that they know exactly what they're buying and what they're buying is alternatives to payer-based wellness programs or freestanding vendor-based wellness programs where you as a community-based physician become the source of a wellness program, not necessarily to reduce their medical claim cost, but to reduce other ancillary expenses the employer might have, for example, in the workers' comp arena, or in terms of improving the overall productivity and satisfaction of the employees that work for that smaller employer who is community rated. So for experience rated, it is an opportunity to become a little bit more involved in reducing the rate of increase, if you will, that experience rated employer might have during the renewal process. So in working with an experience rated employer, for example, you want to find out when their anniversary date is. You want to find out when do they either shop for an alternative health plan in order to keep the premium rate low, or when do they normally get a renewal and have an opportunity to push back a little bit in terms of what that rate increase might look like. And an experience rated employer will get reports during the calendar year that set the stage for the renewal conversation. So part of what you want to be able to do is become somewhat versed in looking at experience rated reporting that comes through. And you want to look at creating a business model that actually helps the employer speak more positively about the health status of their entire population. So if you are fortunate enough to be the primary care physician for the entire population, then in theory, you can sit with the employer during the renewal with either the broker, consultant, or the health plan representative directly, and speak from a position of intelligence around the health status of the population and why the health status of the population has improved or how it's improved to the point where the renewal that's being proposed is really not appropriate, really not accurate, and needs to be reconfigured, recalculated based upon aggregated, de-identified insight that you have, frankly, as the chief medical officer for that particular employer. So as you present yourself to the employer, you want to present yourself obviously for the broad range of primary care that you can offer to their population, but you can then also present yourself as the expert in the room around what the risk factors are for the entire population to facilitate the most appropriate renewal rate for that particular employer. It really does change your relationship with the employer and makes you an advocate, not just for the patient population, but also for the employer and their interest in offering an affordable health plan model. For the self-funded model, self-insured model, that product line is the most animated and the most entertaining, because in that instance, you are working hand in hand with the employer as the sort of the purchasing agent for that employer to ensure that debits to their health plan account are as little as possible and as infrequent as possible once the prepayment has been made to you. And there you're allowed to innovate as much as you can in as many ways as you can in order to deflect downstream spending, or when downstream spending is truly indicated based upon your assessment as a clinician, you're able to then pull in resources that allow you to guide the purchase of those services from the most cost-effective venue. And there are various organizations that we've become aware of as Employer Advantage that really help facilitate that process. And frankly, only through a primary care model can the employer can the employer rest assured that those more efficient and effective and cost-effective strategies get maximized rather than just used either accidentally or occasionally because a patient bothered to call a phone number or check a website for the price of something. And that's been our message to the self-funded employer all along, is that they're putting information in front of their population as consumers, where the consumer is inherently ignorant around what they need and what's best for them. And so the product line strategy for a self-funded employer, frankly, is driven by a true return on investment conversation, the pay me now versus pay me later conversation, where primary care gets to shine, frankly, as a true investment, and how paying in advance of care can truly benefit and reduce downstream spending. And just for purposes of simple math and ratios, we continually hear about, primary care or physician services are only 4% of what an employer spends. Well, what does that mean in terms of real dollars? It can mean any number of different things, because more and more physicians as employees, for example, of a hospital, their services are actually folded into the hospital bill, hospital expense. What we like to do is say, for an employer who might be paying as much as $650 per patient per month, if they simply could see their way clear to invest $65, for example, per patient per month in primary care, they stand a reasonable chance of reducing that $650 down to something closer to $450, including the investment in primary care. So you can begin to see what the real dollar impact can be. And again, it's another service that we provide. We help model the underlying financial terms and conditions so that both the self-funded employer understands and the primary care community understands what the financial targets look like without necessarily transferring financial risk to the providers, but paying them well enough in advance to be able to get the job done. And so the self-funded model is, as a product line, is the most animated. So if you want to serve all three elements of the employer community, I would strongly suggest, and we can certainly help you create the necessary materials and conversation, so that if you're talking to a community-rated employer, you're saying you're sharing a message that resonates with them. If you're talking to an experience-rated employer, you're sharing a message that resonates with them. And then finally, when you're talking to a self-funded employer, you are genuinely understanding and being viewed as a real strategy to reduce downstream spending, because that's their big pain point. Now, in order to get into this game, you're going to have to do some evaluation, particularly if you're going to do multiple product lines. You're going to have to do some semblance of evaluation as far as what are you currently capable of and what do you need to be capable of. And so I would strongly encourage you to consider outsourcing things rather than building things. Outsourcing gives you immediate credibility and ability to do something. If you build it yourself, it's going to take a while for you to get competence in that area, and you're going to lose valuable time in the process. You need some element of data analysis. Certainly we want to disconnect primary care from being nothing more than code monkeys, which is this notion of finding the correct code in order to generate enough revenue. But we don't want to remove primary care from that important process of demonstrating value through data. I mean, data remains important, regardless of, and physicians know that well, based upon their time in medical school. You want to have some ability to do wellness services. Either you have that competency yourself or you find that competency in the community. And again, we can help find state-of-the-art, best-in-class wellness capabilities that you can embed inside your primary care practice and make it an extension of your primary care practice. And as such, the dollars for wellness services will then flow through your practice. Disease management services, again, develop that capability or outsource that capability so that you immediately have that capability as you consider who it is that you're selling to. You want a care management, care coordination capability. In other words, you want efficient and effective referred to program capability. You want to be able to track where your referrals go and map the impact of your ability to select the most efficient and effective clinicians downstream. So with that as the backdrop, Cinnamon, I'd like to open it up to questions now. We have about 15 minutes left in the hour.
Okay, that sounds great. I just want to remind everyone that if you'd like to join us by computer, you can use the microphone icon on your screen to unmute yourself and ask a question. You can also type a question in the chat box. For those of you listening in by phone today, you can unmute yourself by pressing *6. Go ahead and open it up to anyone who has a question at this time. Okay, we do have one question listed. Just a moment, sorry. It says, are there any issues with partially self-funded plans offering us as part of their benefit, like with ERISA regulations?
And the answer is no. To the extent that the services that the self-funded employer, and ERISA is the Employee Retirement Income Security Act. It governs two areas of benefits, self-funded, self-insured plans, as well as retirement plans. And so, no, you want to be prepared to have true business agreements that outline what services are being purchased from you by the employer on behalf of the covered individual. Because what you want to be able to do is then be able to point to the fact that you indeed delivered the services that were purchased from you on behalf of the covered individual. So the only issue, you can't do any of this, or you shouldn't do any of this, rather, you can do anything you want, but you shouldn't do any of this in a casual manner, particularly in an ERISA environment, because how those dollars are paid and what services are received is a part of their effort to regulate self-funded employers to make sure that the money, because often a portion of the money is also being collected from the covered individual through a payroll deduction. And so, you know, the employer may choose to pay all of your fee. They may choose to share a portion of your membership fee with the covered individual. But regardless, you want to approach every agreement, or excuse me, every relationship as a genuine business relationship, and as such have a bona fide business agreement, which again is part of the support that we provide, frankly, to the self-funded employer who's interested in moving in this direction, in order to make sure that they have what they need in order to protect them as well. So that's really what the issue is. Is making sure that the services that you're planning to provide based upon a payment you receive from the employer, either in whole or part, is, you know, that These are the services that you will deliver. And again, getting back to the concept of data, you would need at some point to be able to demonstrate that you genuinely provided the services to the covered population in an aggregated way, not in an individual person way, but in an aggregated way, so that at no point in time does anybody believe that you are, quote, taking the money and running. And we call that capitation under an HMO arrangement. Just kidding.
Thank you, Jed. Does anybody else have any questions? Oh, here's one. It says, I have found that the self-funded groups think this is too good to be true, even after showing data from other companies. How do you get around this mindset?
Well, it's really the psychology of the whole thing. And frankly, it's also part of where we evaluate the employer to determine how serious they really are. I mean, it's interesting that you present this kind of question. We met with an employer in St. Louis, and her perspective was that no doctor would ever do this, that doctors are, just too interested in money and are not interested in really being of value. So to a point, with fact, you can help them overcome some level of skepticism. However, if that hill's too high to climb, then it may be an indication that the employer is, if they think it's too good to be true and the data does not convince them otherwise, it might be best just to say thank you for your time and walk away, because it may be this time, it might be something else next time. So any business arrangement that you execute or have with anybody, you constantly have to evaluate, is this relationship really worth the effort you're putting into it and the compensation you're getting for it? But that's not surprising, and typically it does take a little bit of psychology to figure out where is that obstacle coming from, where is that question coming from.
Do we have any other questions at this time?
The other, just to pick up on that again, that's the other reason why we use that employer's data, not somebody else's data. That's why it's an important part of the exercise, if you can do it, to use that employer's own data so that it really relates to them and not someone else. So, other questions?
Looks like there are no further questions at this time, Jed. Is there anything else you'd like to add?
No, just that we have some upcoming sessions that folks might want to take a peek at, offering a near-site on-site clinic option, giving employers what they really want, and how to become part of that overall benefit plan.
Yes, absolutely. So contact us if you are interested in registering for those. I guess that is going to be all we have for today, and we will make a recording of today's program available to you all soon. So thank you so much, everyone, for joining us today, and we hope you have a great afternoon.
Excellent. Thank you.